I'm going to talk about molecular imaging for in cancer for the layperson. I want to talk a little bit about my take of molecular imaging. For some of us, I have to go back in time a little bit and talk about the molecules of life, if you remember them from biology or chemistry, you know, from oxygen, water. Then we get a little more sophisticated: choline, glucose, cholesterol, and estrogen. I'm also sort of my kids say I'm a sort of amateur historian. My son is the historian, but I'm the amateur. That's why he did this. So I want to go back in time, even long, long ago, in a faraway land, as they talk about. So this is Wilhelm Conrad Röntgen, and in 1895, he was interested in the fluorescence of lights. Remember those old stick lights? Well, he was well before those stick lights that we had when we were way back when. He was interested in the fluorescence of lights, and he got a new tube that one of his buddies had made for him, and it didn't fluoresce. It was defective. But then he noticed if he put his hand down on top of the uncovered plate, he could create an image of his hand without even exposing the plate to light. And he did this over and over again because he was a good scientist. He didn't know what they were called, so he called them X-rays. And he announced this in 1895. The world was small then, and we started to understand that we could do anatomic imaging. We could see the ribs standing out from the chest, the shadow of the heart. If we took them of the extremities, we could see the knee with the kneecap, etc. So in February of 1865, the person on the left, Henry Becquerel, he was interested in the fluorescence of solids, of crystals. If you remember going to a science museum and they would expose crystals and then they would fluoresce sort of purple. Well, he was interested in the fluorescence of crystals, and he got a new shipment of what I would call rocks from one of his buddies, and they had come from an area that had different colors, different properties to them, and he was interested in fluorescence, and he had to expose them to natural light. Well, if you've ever been in Paris in February, there isn't much natural light. It was kind of like one of the days last week when it was overcast. So he threw his new rocks, crystals, into a drawer with, again, a photographic plate that was not open. And when he opened up and created the photograph, he had these impressions of these stones, or pictures of these stones. Now, he had heard about what Röntgen had been talking about. Röntgen, who was interested in the fluorescence of light, fluorescence tubes, had come up with this sort of X-rays, and he knew that this was similar, but he didn't know how. But he was a full professor, and he needed someone to figure this out. So his friend Pierre Curie had a wife who needed a good project. So it became Marie Curie's project to discover what those rays were. Those we now call gamma rays. Röntgen ultimately won the Nobel Prize in physics in 1901, and in 1903, these three won the Nobel Prize for gamma rays. So this led to the kind of nuclear medicine imaging that we saw last half hour, functional imaging. So not structural, but our ability to breathe in gas, or for our bones to create new, remodel itself and make new bones. I'm going to fast forward now to a more current generation, 1971, October. This is Dr. Godfrey Hounsfield, and he was interested in not making just plain flat pictures, but he wanted to make three-dimensional, or at least two-dimensional pictures. And he is the developer of CT. And from that, we're able to make nice slices of, in this case, someone's chest to show the two-dimensional relationship between the chest wall, the ribs, the lungs, and the heart. Certainly an important step forward. In the next year, some gentlemen here in the United States, three of them, Michael Terposian, Michael Phelps, and Edward Hoffman, they were interested in, again, creating two-dimensional and eventually three-dimensional pictures of functional images or molecular images with a PET scanner. So it's interesting how parallel these worlds sometimes can be. And with molecular imaging, what we can do with PET scanning is to create pictures of different types of molecules, whether they be glucose or thymidine or estrogen. We can make molecules. So when we think of these molecules of life, they're really important to our well-being, to our cells. So when I think about cancer, I think about, well, what makes a cancer cell? Why is this cell a cancer cell and not this cell right here? What makes it different? Well, they've lost that loving feeling. They've lost those control mechanisms, those normal things that make cells so very special. Then what they do is they have uncontrolled cellular multiplication. They invade tissues they're not supposed to invade. And really and truthfully, what kills most of patients with cancer is the fact that the cells break off and go live somewhere else, and they grow somewhere else. So this distant spread. Cancer cells, when we look even deeper inside of them, they have a voracious need for extra stuff that they wouldn't have needed if they had been under control. This voracious need, they need more DNA. Our blueprint of our cells, they need to multiply that and make more of it. They need more proteins. But really, one of the things that many of them need, they need more energy. You know, you may turn to a Snickers bar or whatever else you have, a Coke or whatever else you have in front of you when you need energy. But a cell is going to turn to the primary sugar, one of those primary sugars. You've all heard of fructose, that high fructose syrup that people are concerned about. Well, glucose is the site where our cells churn for energy. It's a cousin of fructose. It is the easiest way in mammalian cells to get energy, and cancer cells know how to turn that on. This is glucose, and we've actually known since 1930. Dr. Warburg published in 1930. He said, you know, the difference between a cancer cell and a normal cell is that cancer cells use glucose, this special sugar, 4 to 40 times more than normal cells. So in the 1960s and 70s, they were trying to figure out a way to use this. Dr. Ido found a way to make this glucose radioactive, to make it give off gamma rays like Marie Curie had worked on. And so with some of those new machines that Dr. Phelps made, we could make pictures. So we got to understand that this material, this radioactive material called FDG, is pumped into cells just like normal glucose is pumped into cells. And it accumulates in cells in relationship to this pumping. Boom, boom, boom. It can't be used for energy because it's just a little bit different, but it can be pumped into cells. So when we put people in a PET scanner, we can see that the brain, an obligate glucose user, it's the only way it can get glucose, shows up. We see the heart because it's pumping all the time and it often uses glucose. We see a little bit in the liver, and we see the kidneys and then the bladder. How's that old cancer cell different? Well, it says, hey, I need more energy. So the easiest way to get energy is ask for more glucose. So it puts more pumps on the surface of the cells. It brings in a lot more glucose. Again, like Dr. Warburg saw in his little laboratory, 4 to 40 times more glucose. And it pumps in and it builds up because it can't be broken down because it's a little bit different. And so we're able to see the foci of cancer in and amongst the normal tissues, which when we're resting are pretty much quiet. This is a 37-year-old woman who was told, unfortunately, by her doctor 10 years ago, at the time this was done, that she had no evidence at that time that she had cancer. Well, we were able to provide him with some additional information, unfortunately, for this woman. But they did move on then to treat these, unfortunately, 40 different cancer sites that we identified. And you can see them in this spinning image as the bright spots that weren't there on the other image. So how do we as physicians use this? Well, sometimes we ask fairly simple questions. Some of the same questions that patients are asking is, do I have cancer? Is that spot that they found in CT, is that really cancer? One of my friends says, this is my molecular biopsy. Sometimes I don't have to put a needle in everywhere. I'd like to know I can use the metabolism, the use of glucose in this case, to tell whether this spot is likely to be cancer. Again, nothing's perfect, but this is a way to measure, is it likely to be cancer? Unfortunately, in this person, it's very likely to be cancer because it was. Another question that we often want to know is, okay, I have cancer. Where is it? We, as doctors, want to know everywhere it is. We often use a word called staging. We want to know how big, how advanced, is it in the bones, is it in the lymph nodes, where is this? And unfortunately, many patients, when we started to use this technique, we had, relatively bad news. Fortunately, sometimes my job is I'm the bearer of bad news. But I look at it the other way, is I'm not telling them something that wasn't there. I'm telling them something they maybe didn't know. But as we get more sophisticated seeing cancers, we often get more sophisticated treating them. If we can't see them, we can't treat it. And like I said, in some cases, we're getting a bit more sophisticated. And one of the things that we can do that was touched on last half hour was we can actually measure with relative degree of certainty how that person is doing, even as quickly as one day. You can see up here in the neck that we have a spot of cancer, 2 spots actually, that are melting away even with 1 day of treatment, and things continue to get better in the abdomen through day 20 and 120. So we can not only see it, we can measure it, can't quite feel it, but it gives us a sense of just what rapidity this patient happens to be responding to the treatment. If we think mathematically, we draw a point and we're able to measure that fairly exactly, and we're able to measure a point at some time in the future, we define the slope of that line. That slope of that line is proportional to the number of cells that are being killed in some of our tumor treatments. And that becomes very important to the physician, because then he knows how rapidly this cancer happens to be responding. And as we get smarter about individualizing our treatment, your slope, your cancer is not going to be the same as mine or anyone else's. And so we can individualize, this person responds quite rapidly. And as a consequence, may need something very different than a person who responds much more slowly. And it just makes us smarter because we're able to measure what that response is and individualize therapy. I want to talk about another one of those molecules of life. Some of you may have seen this because I know I did this someplace else. But I talk about we have literally more than 2,000 molecules that we have worked with. This one is choline. It's one of the ones we happen to be working with now. And choline is important in our body for a number of reasons. But one is that it becomes this long, big material called phosphatidylcholine. Maybe a while back, but phosphatidylcholine is what makes cell membranes, the outside surface of each and every one of our cells. Not only do cells need energy, but guess what? If we're going to make more of them, got to have more membranes. So with prostate cancer, we're looking at many features with a radioactive choline. In this case, how advanced is the disease in and around the prostate? Has it spread outside of the prostate like this one did into the seminal vesicles? How advanced is that? We're looking at spread to the lymph nodes, especially when people have been treated initially and now their PSA is rising again and we can't seem to find it. This is a way that we're able to find it, in this case in the lymph nodes or in the bones. When many of our other tests, even some of our other functional tests are negative, we're able to see it within the bones. It gives us another sense, another appreciation for what's going on. One of the things that's been nice about this material and others is that we can direct therapy more appropriately. Does this person have a bunch of spots? No, he's got 2 spots. Now we can radiation, and the radiation person is going to paint both the cancer areas and the important non-cancer areas that he doesn't want to damage. He's going to create with the computer a way to cover these areas with radiation where he can focus the radiation specifically in the red spot where he knows the cancer is and cover the other areas less intensively. So smarter therapy. And then from those we can measure and determine, in this case, response to therapy, where this area in the bone goes from a very bright choline-avid spot to no spot at all because it healed up. The hole in the bone had healed. So I'm going to close because I gave you a very brief sketch. So our PET scans provide molecular imaging pictures of those molecules of life. Simple molecules, maybe sometimes more advanced molecules, but it gives us a picture of what's going on. Yes, cancer cells turn to glucose for energy, and we can use that in our traditional PET imaging to find many of the cancers. But we're branching out to choline and other materials that are important building blocks in the cells, in these cells that have gone to the dark side. Molecular imaging allows us to measure, to better visualize, to visualize it earlier, to allow us to attack and individualize therapy. I want to acknowledge that I'm part of a team. This is not one person doing this. This is a host of nearly 126 people that I work with that provide molecular imaging services on a daily basis. We see upwards of 40,000 patients each year for PET imaging. and for other kinds of molecular imaging. And no one does this as one person. So when you see the word molecular imaging, think of us as mapping and measuring the molecules of life. Thank you.